I'm Kevin Bowman. I'm the Chief Resident of General Preventive Medicine Residency Program here at Johns Hopkins. The Preventive Medicine Residency Program here is the oldest and largest in the country. It's been around for, I think, over 40 years. We are about 25, group of 25 physicians trained in clinical medicine and also population health, public health. Here at the school, probably many of you have seen the residents in classes. This is our grand rounds. We like to do a couple times a year on topics that are relevant, and we thought this would be a very interesting topic that many people would want to hear about. To that end, I will now introduce my program director, Dr. Miriam Alexander, who will take it away and introduce the speaker for today.
Hi, good afternoon. I'm glad you're all here on this rainy, sort of ugly day. I'm Miriam Alexander. I'm the director of the Preventive Medicine Residency Program. I'm also the director of the Mid-Atlantic Public Health Training Center, and it's a joy for me to be doing this grand rounds, both from a preventive medicine perspective and a public health training center perspective. And to that end, we are now, today's grand rounds is being webcast, and we're a webinar, so all of you folks will be part of the video and audio. I'd like to welcome all of you to our grand rounds, and I'd like to welcome our web audience. I understand we have public health practitioners. We better have all our preventive medicine residents who are not here online. Hi, guys. We have many other guests, and I know that we have people working with Dr. Morlock on programs across the country, and I'm very excited to have you all here. This particular subject by Dr. Herring is especially relevant to all of us in preventive medicine. You may know that there's a significant provision for preventive medicine and public health, which is very exciting to us in preventive medicine and public health. We actually receive training funding through provisions of the ACA, which is very exciting for us. One of our chief residents here at Hopkins, Dr. Charles Preston, and I wrote an article on the prevention pieces of the healthcare reform legislation. I'd like to call your attention to it, summarizing the prevention pieces of this legislation. But most exciting, we are pleased to have Dr. Herring with us. Dr. Herring is well known to those of us in the audience, but for those of you who are not part of our actual school community, he's a faculty member here in health policy and management with expertise in health insurance. He's beloved by all of us, especially our preventive medicine residents who take his very popular course in U.S. healthcare. I'd invite all of you to ask questions at the end. For those of you who are online, please submit your questions electronically through the link on the web page. And for all of you who are here in person, please join us for a delicious reception afterwards. For those of you watching, you'll have to enjoy our gustatory pleasures virtually. Dr. Herring.
Wrong way. Okay, so thanks so much, everybody, for coming. Really happy to do this. So what I'd like to do is basically spend 30 minutes, 45 minutes talking about where things stand with implementing the Affordable Care Act. This legislation passed over a year ago, and so what I'd like to do with this presentation is spend maybe about 10 minutes or so, maybe 5-10 minutes or so, giving a quick overview of the legislation and since the purpose and then some of these main provisions. From there, I'd like to transition and in some sense kind of talk about how things have developed since its passage. If you weren't aware, it was a very, very partisan and contentious bit of legislation that many of us thought, well, once it passed, we'll just kind of move on and start working on implementing it. But that's not really been the case. It's still been very, very political. And so what I'd like to do, going through several examples, is actually try and distinguish the notion of politics versus policy. And I'll do that kind of in the second bit of this presentation. So then I kind of thought, well, if you think about maybe what are the biggest issues in terms of implementing the Affordable Care Act, I guess in my opinion, it would seem to be the health insurance exchanges that are set to come online in 2014 and the new accountable care organizations that will be developed. So I'll spend some time talking about those two things in particular. Okay, so starting off with an overview of the Affordable Care Act, if you really think about it having three main goals: one, to cover the uninsured by subsidizing their coverage; two, reduce healthcare spending. Many health policy analysts and advocates referred to this as bending the curve; and then also trying to increase the amount of regulation on health insurers to, in turn, hopefully maybe impact covering the uninsured and reducing healthcare spending. So as far as the uninsured go, the number has been growing. The proportion of the population has been growing as well. We're now at almost 51 million uninsured, representing about 17% of the population. When people talk about bending the curve, this is what they're talking about. This is healthcare spending as a percentage of GDP, with the blue dots, diamonds, if you will, showing historical data, and the red square showing projected data, right? So if these data hold true by 2020, we'd be spending about 20% of our economy devoting that to healthcare. Okay. So in steps in the Affordable Care Act, does essentially, a whole lot of stuff, but if you think about the main things, if you're trying to boil it down to one slide, as I've done, it's trying to cover the uninsured through a couple things. One is expanding the Medicaid program geared for low-income families to cover essentially all adults under 133% of the poverty line. Poverty line for a single individual is probably about 12,000 or so, 22,000 or so for a family of four. Okay. So expanding the public Medicaid program. You're also creating new health insurance exchanges, which I'll just describe in more detail later. But in terms of trying to cover the uninsured will get tax credits to offset a portion of their health insurance premium if they're purchasing as individuals through the exchange. And so specifically, tax credits that reduce with someone's income in between 133 and 400% of the poverty. And so you can think about these exchanges as trying to reform the marketplace for individual and small businesses. And I'll, again, go through more detail a little bit later. Another big element of the healthcare reform was to prohibit the use of chronic health conditions, pre-existing chronic health conditions by insurers, so that essentially if you have a chronic health condition come 2014, you can no longer be charged more or denied coverage. So the thing is, and this is something that economists really focus on, like myself, if you do that, well, then you have the potential for adverse selection where the healthy people might forego coverage, sicker people more likely to get coverage, and that in turn gives the motivation for having this individual mandate in place to have people get coverage or pay a penalty. And then associated with that is an employer mandate to get them to offer health insurance coverage or pay a penalty. Okay. So the Congressional Budget Office, the official scorekeepers of all this legislation, project that in the absence of the healthcare reform legislation, we would have had about 54 million uninsured once it's fully implemented. And this legislation will cover about 60% of them, 32 million. So if you look at how health insurance coverage is projected to change, on the left side here, you've got how things would look in the absence of the law. And over on the right side, you have how things are going to look, most likely, having passed the law. So if you focus on the Medicaid population, you can see that the people for whom Medicaid is their main source of health insurance coverage, that population is going to grow by about 50%, from 10% on up to 15%. The proportion of people with employment-based coverage is going to stay the same, but there's going to be a lot of movement in and out of this group as firms drop coverage and other firms start to offer health insurance coverage. But then if you focus here on the 16% of the population projected in the absence of the law, that's projected to come down to 7%, with, again, many of them going into the Medicaid expansion, and then many of them gaining health insurance coverage through these new health insurance exchanges shown in orange. Okay. So that's kind of the snapshot of what will take place in 2014. And so a lot of work in terms of implementing healthcare reform is trying to get all that stuff squared away and get the exchanges in place, think about the Medicaid expansions, et cetera, et cetera. And I'll return to some of these issues, but also just real quick kind of highlight some of the big ones, I guess the big secondary provisions that have been implemented over the past year or so. So high-risk pools existed prior to the Affordable Care Act in about 30 to 35 states. These are sources of health insurance coverage for people with chronic health conditions who can't get coverage. The Affordable Care Act sent money to those states to kind of bolster their programs and provide money for new high-risk pools in the states that didn't have them. And so these are essentially temporary things because in 2014, the need for them should go away as community rating provisions take place. Another main provision that got a fair amount of attention was allowing dependent children up to age 26 to maintain health insurance coverage through their employer. And so in terms of the Obama administration trying to promote things that happened early on, this was a big one. Another one that probably actually didn't go so well was implementing right away a prohibition on using pre-existing conditions for children. That took place 6 months after the passage, so yeah, I forgot to mention that's what I've got designated in the parentheses. The downside there is essentially the insurers said, well, if you're going to have us require us to issue plans without being able to take account of chronic health conditions, we're essentially going to exit the market. And that's actually what happened in many of these individual market plans for children. The people that had their insurance could keep it, but the new plans kind of withered away a bit. Small business tax credits to try and get small firms to offer health insurance coverage, also included in the legislation. And so the IRS has been working on getting these things, getting awareness for those things out there. Some other main provisions is trying to make health insurance a little bit more generous by having preventive care free, no co-payments, and doing away with annual and lifetime limits. So that all sounds good, but that in turn is going to raise the premium. And so there's been a fair amount of tension between the insurance industry and the administration in terms of what this is going to mean and what might acceptable increases in premiums be. A final kind of main secondary provision is that the so-called donut hole for Medicare coverage is going to be filled in. And so currently, the donut hole is a gap in coverage for people with kind of moderately high spending, where after their insurance has covered drugs, it goes away, they've got to pay the full out-of-pocket cost. As a result of the Affordable Care Act, pharmaceutical companies will be granting 50% discounts to people while they're in that donut hole. And as far as implementing that goes, it hasn't really started yet, but I'm curious to see how that whole mechanism of sending money from the from the manufacturers to the people will actually play out. Okay, so if you think about the Affordable Care Act overall, you've got a lot of spending, mainly on the Medicaid expansion and the tax credits for individuals. That's shown in the darkest blue bars here over a 10-year budget window. And then you've got to cover it some way because they wanted to do this in a way that was fully funded. And so you've got the medium blue segments of this graph, essentially reductions in other government spending to pay for the healthcare expansion, and new taxes shown in light blue. So what are some of these main financing provisions? Well, to cover the $938 billion over the 10 years, there's an increase in the Medicare payroll tax for high-income people. There's going to be reductions in the updates to payments to providers over time that'll compound as the thing grows. Reductions to so-called Medicare Advantage plans. These are private plans that serve about a quarter of senior citizens. A quarter now, that's pretty much going to drop because of these reductions to the plans. And then finally, some fees on drug manufacturers, medical devices, and health insurers. Okay, so how did I do there? About, your 10-minute overview of the Affordable Care Act, right? So with that, let's start talking a little bit about the politics, right? So as I said earlier, I mean, this is very, 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 very partisan. And so what I've got here are essentially different votes, right? So the Senate passing the Affordable Care Act was, strictly partisan. 60 Democrats in favor, 49 Republicans against. In the House, again, very, very partisan, with some of the Democrats going over to vote against it. Once the new Republican majority swept into the House, they had the so-called Repeal the Job-Killing Healthcare Legislation Act, affectionately known as RJAGLA. Extremely partisan as well, right? All Republicans voting to repeal it, 3 Democrats actually saying, yeah, let's repeal it, versus all Democrats saying, no, let's not repeal it, we're still for Affordable Care Act, right? So you can also think about this partisanship maybe even spilling over into to judges, right? So as I'll talk about in a couple minutes, one of the issues with implementing the Affordable Care Act is whether the individual mandate to incentivize people to get coverage, whether that's constitutional, right? And so there's been attorneys general that have brought up these lawsuits, and the rulings so far have gone, as you might expect, in terms of a partisan relationship, with 2 judges appointed by Bill Clinton saying, nah, mandate's okay, and 2 judges, I think, appointed by Bush Sr., Bush Jr., saying, no, the individual mandate is not constitutional, right? So ultimately, this has got to go to the Supreme Court, it seems, okay? So moving forward, if you think about like what Democrats are trying to do strategically, it's just, hold the fort, right? So try and deflect any kind of additional attempts to repeal the ACA. They might have wishful thinking that maybe things will turn around and they'll finally, get what they're yearning for, which is the public option. But I don't see that happening. Okay, switching to the Republicans, well, they ran, arguably successfully on repealing the Affordable Care Act in the past midterm elections on a so-called repeal and replace. Okay, well, they voted to repeal it, replace, not really coming along so well so far. So what is their strategy for the next couple of years? I've written here, death by 1,000 cuts, right? So they're trying to, it seems, just whittle away at spending and certain provisions, one by one, right? So the most recent legislation to I guess, extend the budget resolution included a couple provisions to but reduce funding for co-ops, which is an effort to increase nonprofit coverage in states, and then also killed a provision championed by Democrat Ron Wyden. So they're doing this death by 1,000 cuts, essentially because they can't really do anything more, right? The House can pass legislation all it wants in terms of trying to repeal, but they're not even close in the Senate because there's nowhere near the 60 votes to overthrow the ACA in the Senate. And even if there was, President Obama is obviously going to veto it. So their long-term strategy instead has got to be take the Senate in 2012 and take the presidency in 2012 as well. So now let me transition into maybe some specific examples with now trying to even focus a little bit more finely on this distinction between politics and policy, right? So policy is maybe, what can a bunch of technocrats think about in terms of trying to devise better healthcare systems. And politics is essentially Republicans and Democrats playing, debate club, high school debate club. So you can kind of think about this as a lot of examples of inconsistency, right? So I thought about using hypocrisy, but then I realized it's going to be recorded, so I better just use something a little more bland like inconsistency, and so thought of this criticism of John Kerry in the 2004 election about him being before he was against it. But hell, you can even think about some people now being for it again. So Medicare spending is a great example of this, right? So back in the 1997 Balanced Budget Act, you had President Clinton kind of going along with congressional Republicans to reduce Medicare spending, right? So Republicans have kind of been the party of reducing Medicare spending. Until the 2003 Medicare Modernization Act, which added a drug benefit, increased payments to private plans, and essentially kind of abandoned that and actually increased spending. Okay? Well, then they reversed course a little bit so that when McCain runs for president in 2008, part of his healthcare platform included reductions in Medicare spending, and Obama killed him on it, right? Oh, you're going to kill Granny, that kind of stuff. Until, a year later, when the Democrat proposal comes out, it's the Affordable Care Act, and now the Democrats are pushing forward on Medicare reductions, and now the Republicans are trying to kill the Democrats over what they're doing to Granny. Okay, so then that's all well and good until now. Most recently, 2011, the House Republicans have put out a proposal to really decrease Medicare spending off into the future. And Obama has countered with making the Independent Payment Advisory Board, which is essentially an agency, a newly formed agency that will try and work on modifying Medicare payments. His recent proposal is trying to give them a little more leverage. Right? So that's kind of a little bit in terms of like past and then perhaps prologue for where we're headed with Medicare. I mentioned the individual mandate, so what's ironic here about some inconsistencies is that this was actually initially kind of put forward as an idea in the early 90s by a conservative economist, and they were trying to kind of work on an alternative to what Bill Clinton was proposing, thinking what Bill Clinton was proposing, or even single payer, was going to be too far to the left, so let's kind of come up with something else, which ironically turned out to be very similar to the Affordable Care Act. But in it was this proposal to have a mandate, right? So we have a penalty on people if they don't get coverage, provision within the Massachusetts healthcare reform, the individual mandate, championed by Republican Governor Mitt Romney, who now has distanced himself totally from that success back in 2006 because he's trying to win a Republican primary, and the Republicans in the primary just hammering him over what he did with Massachusetts. Mandate also became a big issue in terms of the debates between Obama and Hillary Clinton, in terms of Hillary Clinton having a mandate for everybody, Obama arguing that he didn't want to have a mandate for adults. And that got a lot of attention during the debates, and then fast forward 6 months to a year, now Obama's comfortable with a mandate for adults. And so I mentioned earlier, lots of lawsuits ultimately going to the Supreme Court, we think. Another couple of examples with some of these inconsistencies, if you will. The tax subsidy for employment-based health insurance has been something that economists have been griping about for years, right? And so I got this little joke here. Maybe I'm probably the only one who thinks it's funny, but in 1954, the IRS made a ruling that health insurance benefits could be considered, exempt from taxes. And so I bet there's an economist somewhere who kind of said, wait, that might be problematic, right? So presumably, right? So long time, health economists have been arguing that there might be some inefficiencies and inequities associated with the tax subsidy. More recently, you got John McCain introducing a proposal that would have tweaked well, probably more than tweaked, but impacted the tax subsidy for employment-based health insurance. And Obama just nailed him hard in the debates. You're going to do what? You're going to tax health insurance benefits? That didn't go over very well. Until then, fast forward to the Affordable Care Act. Well, what's Obama advocating for? A tax on employment-based health insurance benefits. I mean, through a different mechanism, but it's essentially a similar thing, the so-called Cadillac tax, which will be a tax on really high-cost plans. He got hammered on both sides. I mean, the unions hated it, liberal Democrats hated it, Republicans were nailing him on it because it's a tax, we don't like taxes. And so in some sense, I think it's kind of a miracle that the Cadillac tax stayed in the Affordable Care Act, and I think that was probably at the urging from some economists within the Obama administration, right? So the Cadillac tax is scheduled to be implemented in 2018. Given how politically unpopular it is, I don't know. I'd be shocked if it goes into effect. So let's all get together in 2018 and see how things played out. Okay. A fourth example before heading into more detail on the exchanges, and then in turn, what I'll do is try and cover the provisions about the accountable care organizations too. Health insurance exchanges have seen a little bit of flip-flopping as well. In some sense, you can actually go back to Bill Clinton's healthcare proposal, which included HIPICs, health insurance purchasing cooperatives. And these are not too dissimilar from health insurance exchanges, which were later then advocated by the Heritage Foundation, a very conservative think tank around 2006. Heritage Foundation was in turn involved with getting the reforms passed in Massachusetts with the exchanges, or what they termed them, connectors, as a centerpiece. And then fast forward to the Affordable Care Act, prominent feature within the Democratic proposal with negative reactions from Republicans. Okay. So what then is a health insurance exchange? Well, the hope is that it might look something like this, right? So imagine you log on to your computer and go to a website, and you're able to choose among health insurance plans in this fashion, right? So it kind of, maybe reminds you of, shopping for clothes online, or shopping for hotels or airlines. So you've got different plans here as the rows. The columns representing different aspects of the plans. They're going to be tiered in terms of metals, where bronze, silver, gold, platinum, kind of designating cheapish health insurance plans versus more expensive health insurance plans. And the hope is that you can get this all online, and then people, individuals, small businesses will be able to make choices among different health insurance plans in a more informed fashion, right? So sorting by the different benefits, sorting by the different health insurance plans within each of these tiers, and so on. Okay. So as far as that goes, I think many people, myself included, think that this is the way to go in terms of having people shop for private health insurance. But in terms of the implementation, there's a lot to do, right? So the starting point is that, well, the Affordable Care Act is going to establish or allow state-based health insurance exchanges, but you've got to have states pass legislation to follow through and actually implement them. Because if they don't, then the federal government is going to have a backdrop federal exchange for the states that don't introduce their own state exchanges. So in terms of thinking about what a state legislature has to do, it has to first decide whether they're even going to do it in the first place. And then they can also maybe decide, well, are they going to think about joining up with other states to have so-called compacts, where you could imagine maybe Delaware wants to join the Maryland health insurance exchange, and then it's insurance for everybody in those two states. States are also going to have to decide whether they want to carve out the population between 133 and 200% of the poverty line and put them in one private health insurance plan that's kind of more like private Medicaid HMOs, so that the resulting exchange might be for individuals between 2 and 4 times poverty. And you can think about the pros and cons of doing that. States are going to have to think about whether to allow additional benefits beyond what the federal government is going to designate as essential benefits. And then states also are going to have to think about whether to have their boards set up kind of as part of the government, a separate nonprofit, or somewhere in between. Okay. So then, once you get these exchange boards, and then also decide whether they're going to allow insurance companies to be a part of that board, and that's a contentious issue. Okay. So then, kind of shifting maybe to some of the political issues, still some policy issues there, but once you get these exchange boards formed, there's a whole lot to do in terms of trying to get this created. But on top of that, there's a whole lot of work that's going to have to be done for the precursor to this, which is actually to determine what these premiums should be, because what these premiums should be are going to be determined by somebody's income. And actually, there's even a precursor to this web page where presumably somebody's going to go online and try and figure out whether they're eligible for Medicaid or the exchange in the first place, right? So a lot to do in terms of getting eligibility determination down, with the hope of having one single point of entry for people, sometimes referred to as like no wrong door, as people try to gain coverage in 2014. The exchange boards are going to have to work out something called risk adjustment, which is transferring money from the plans that enrolled relatively healthier people to relatively sicker people. A lot of technical issues there, but then also probably going to be some griping from the plans. Exchange boards, sometimes maybe the legislature in the first place is going to have to decide whether to keep individual and small group markets separate or combine them. And then also, and this is probably one of the more contentious ones, whether you're going to allow the exchange board to be quote unquote active purchaser and get involved with the negotiation of premium rates and premium increases. So that would be, thinking about at one extreme, the active purchaser, maybe potentially limiting the number of plans and requiring low premiums, versus another model that might kind of just say, well, let's just make sure that they're all qualified and have them on the exchange and have relatively little oversight. So a lot of things for states to do to get there. I think Maryland's actually way ahead of the curve on this one, in the sense that they passed their legislation to establish a kind of quasi-public exchange board in this past session, and other states are kind of still in the process of doing this, but they got to do it soon, because there's a lot of work to get done by 2014. Okay. So let me now talk about this other big sexy topic, if you will, if you think exchanges are sexy. I do. I don't know. Maybe you don't. Accountable care organizations, right? This is another one that's getting all sorts of attention, in part because I think people are hopeful that these will transform the delivery of healthcare in a way that actually starts to emphasize primary care in a lot of ways. But then also, optimistic about them slowing the growth in spending. And then also, in turn, a proposed rule came out from CMS several weeks ago. So researchers and consultants are spending a lot of time trying to figure out what that 400 and some odd page document really means. Okay. So the affordable care, so here's going to be my quick attempt at a 5-minute overview of accountable care organizations before opening up for questions. The Affordable Care Act established the Medicare Shared Savings Program, which will in turn create the potential for accountable care organizations to form and in turn get some money back through a formula I'll describe. Okay. So the thought, kind of this generic thought about what an accountable care organization would be, the hope would be that you'd get all the providers, the major ones like hospitals, primary care physicians, specialists, together in an accountable care organization. Hope that it's wired so that there's electronic systems connecting everything. And then that entity, the accountable care organization, will essentially be responsible for the care of the people that go to those providers. Right, so I throw in this caveat here, ideally, because I think CMS is trying to not be so prescriptive and allow for different possibilities in terms of the organizational structure. But if you kind of think about a broad vision, it's really about bringing all those different groups together. And then, in order to qualify as an ACO, you'd have to be seeing at least 5,000 Medicare beneficiaries. But the twist here is that Accountable Care Organization didn't want to say Medicare beneficiaries are going to be assigned to an ACO or they have to pick. No, that would be restricting choice. We can't restrict seniors' choices. So seniors are going to get to go to the providers they want to see, and then retroactively, based upon where they went, we'll figure out which ACO seemed to be most responsible for their care during that past year, okay? And then these ACOs, all the providers within, the physicians, the hospitals, they'll still receive the traditional fee-for-service payments that we've been lambasting all this time for driving up utilization. They'll receive all those payments still, but there's going to be this reward and penalty system in which the actual spending incurred will be compared to benchmarks, pre-established benchmarks. And so that, in short, if the spending was over the benchmark, the plan's going to have to pay some of it back. But alternatively, if the plan can get under that benchmark and save money, there's going to be the shared savings, right? So Medicare is going to share some of the savings, and the plan's going to share some of those savings. And so I mentioned, the consultants ready to go. Here's something I found from Deloitte. Sorry, it's a little blurry, but this tries to kind of, I think, illustrate what an ACO might face in terms of some of these potential rewards or penalties. So imagine the gray bars as either the increase in costs here on the left or the savings in spending over there on the right. So the gray bar, that first one would be, suppose the ACO was able to save, 5% relative to the benchmark. Well, what the blue bars designate as essentially the money that's going to come back to the plan in the form of this reward. And it kind of goes up, but it's capped so that if you go over the 20%, it's kind of capped at that amount. But then there's another twist in the sense that in order to actually get these payments, you have to meet certain quality metrics. So actually, this is a bullet I overlooked, right? So in order to get the share savings, you have to meet some number to be determined of, right now, like 65 different quality metrics. And so if you meet them, if you establish that, yes, we were able to save money, but we were still able to provide high quality care, you'd get the blue bars in terms of bigger savings. But if you didn't, and your quality wasn't so great, you might instead get some of these red bars, right? So proposal is kind of floating around. It's out there. CMS is still going to receive feedback and maybe tweak things a little bit. But in terms of people thinking about, well, what's going on here? What are some of the challenges? One is essentially if you construct like this, so if you build it, will they come? Will you actually see hospitals and physicians pairing up and saying, yeah, we think we like this, we think we can handle it, we think we can handle the downside of the risk on the right, and let's go ahead and give this thing a whirl. That's an open question, right? I think initially CMS is projecting maybe about 10% of Medicare beneficiaries might be getting their care through an ACO, but at this point it's like, anybody's best guess. The hope is that private health insurers will like this model and kind of follow it as well. And an additional hope is that these incentives will be all good and be like, yeah, you know what, we got to emphasize prevention, we got to emphasize high quality care and keep people out of expensive settings and maintain their quality. That's the hope, but then there's also the potentially unintended consequence, and maybe this is something I hinge on as an economist. I don't know, Laura's kind of joked to me about this. There might be these perverse incentives to skimp on care under all these set of incentives, and maybe try and game some of the quality indicators, perhaps. Another challenge here is that, well, you want to have Medicare beneficiaries free to choose the providers they want because you're not going to limit their choice. But then that kind of puts the ACOs in a bit of a hard spot in terms of a primary care physician that's part of an ACO trying to encourage their patient to go to their hospital that's also part of their ACO, but not being able to really prevent that patient from going to a hospital outside of their ACO, right? So if they go to the hospital outside of the ACO, the initial ACO is still responsible for their costs, right? So it's kind of like, well, I'm responsible for their costs, but you're not really giving me all the tools to fully be responsible for coordinating their care. Okay. There's also this notion of, in terms of thinking about how they come together, right? So there's a lot of money to be had, these blue bars, but how are the hospitals and physicians going to think about playing nice and separating this money? And then even within that, how are the physicians going to be separating the money between specialists and primary care, right? We know that there hasn't been any problems along those lines historically, right? Final thing before wrapping up is there's also antitrust concerns, and so the Department of Justice and Federal Trade Commission are on top of this, actually fighting each other for jurisdiction, it seems, because they're kind of worried about this consolidation, maybe bringing multiple hospitals together, having them pair up with physician groups, might yield uncompetitive pressure, and in turn maybe have the ability to charge higher prices, maybe over in the private market. So with that, I'll be happy to take your questions. So thanks so much.
Those of you who are watching online, please feel free to click the link and email us questions.
Hi, my name is Alice. I'm an MPH student here at Hopkins. My question is regarding the freedom of choice from patients' perspective in choosing an ACO. Mm-hmm. So why can't the policy mandate patients to choose given that they have the freedom already to choose their first ACO and then just go with the first ACO, like many HMO plans?
Yeah, so in theory, you could do just that, right? So there's really nothing, in my opinion, other than the politics from implementing just what you say. Look, there's historical precedent for people choosing to be in the traditional fee-for-service program or maybe choosing an HMO. Once when you're in the HMO, the rules are such that you stay in that network or pay, out of pocket. So I think, yeah, you could have done it, but again, I think it's a concern that if you had seniors having to say, okay, I've got to pick an ACO. What's an ACO? That's going to be the route. So what's an ACO and what am I picking exactly? I think even if they understood it, and first there's probably a big difficulty in getting Medicare beneficiaries to understand it because we can't even understand it. But even if they were informed, then I think, yeah, there's this issue of saying, well, you're going to limit my choice of specialists or hospitals, right? So yes, limiting choice would probably save a lot of money, and it's probably like the best way to improve efficient delivery of coordinated care. But people don't like being told that they can't obtain medical care from wherever they want.
Thank you.
Hi, I'm Laura Morlock. Brad, I understand that in addition to states discussing whether to merge the individual and small group markets, there are even some states thinking about putting state employees into this pool in order to increase purchasing power and further spread risk. Is that? Could you talk a little bit about the different kind of conversations going on about this?
Oh,
in the
yeah,
states?
sure. So in some sense, I mean, Laura's comment that the hope is to spread risk, and I think the corollary to that is to increase the bargaining power of the exchange, you know, whether it's explicit because you've granted them an active purchaser status, or even whether it's just implicit because you've set up a free-floating marketplace with few restrictions, but it's covering tons of people, right? The whole notion of covering tons of people ought to get the insurers interested in providing good quality care, competitive premiums, choices that people will like. And so the way you do that, create a nice big marketplace with really good incentives for competition, is you make it, as big as possible, have as many covered lives as possible. And that could mean merging the individual and small group markets to pool their purchasing power. And then as you say, you know, maybe take that even a step further and include the state employees and have them get their health insurance through this exchange. And so, I mean, one perspective, I think, and this is probably consistent with this theme of politics versus policy, I think many people who are advocates of the exchange approach from a policy perspective say, indeed, like more is better, right? So let's certainly have the government employees. Let's add medium and large size employers. You know, hell, maybe even in 20 years we'll add like Medicaid and Medicare, right? And have the state exchange cover everybody seamlessly. And as long as it's, you know, regulated to the extent you want it to be regulated, cool. But then the politics come into play because, you know, in terms of merging the individual and small group markets, you get the populations there saying, well, we kind of like our risk pool. We don't want to be part of your risk pool. Maybe they would say, you know, I don't know about these government employees. We don't want them in our risk pool because they're older and sicker. They're going to drive up our health insurance premiums. So there, I think you get the political tension in terms of pushback about not wanting to spend more and kind of, you know, maybe pushing against that. Yeah. Oh, yeah. Okay, cool. So one online. Let's see. The secretary will describe in regulations the essential health benefits. How will Maryland decide what specific services are covered beyond what is set out in the regulations? Yeah, so good question. Okay, so again, so the process now, centered in the federal government and specifically with the Institute of Medicine, is trying to bring together a bunch of people, decide what the quote-unquote essential benefits ought to be. Like what services, medical services, need to be included in health insurance plans. And there, as you can imagine, that's very contentious because you've got all sorts of provider groups kind of angling to make sure that what they provide, or even maybe interest groups on the consumer side, angling to make sure what they like is included in that essential benefits. So once you establish that at the federal level, then the states are going to have the discretion to perhaps include additional benefits. And the trick here is that they're going to have to cover a cost in order to do that. So the way this will all work relates to the tax credit subsidies for individuals in the exchange. So the way this would work is that if a state wants to add additional benefits, let's say, well, I don't want to name them. This is always putting me in hot water when I try and name something. But let's say you've got the essential benefits, and then the state decides to grow that by adding on some additional services. The thing is, the state's going to have to cover the cost of providing those additional services for low-income individuals that get tax credits through the exchange, right? So imagine you have a $4,000 policy for an individual that just includes the essential benefits. It has to go up to $4,500 to include the mandates that a state passes. So now you've got this $500 difference. Well, low-income individuals who get tax credits to buy a $4,500 plan instead of a $4,000 plan are going to get a bigger tax credit to offset that premium, but it's no longer going to be the federal government paying it. It's going to be the state government paying it, right? So this is something that you can barely understand theoretically or abstractly, but actually implementing that, oh man, that's going to be a nightmare as well. But I think in some sense the initial rationale for that is to say, look, states have kind of historically been easy to pass some of these benefit mandates because it's something they can do, claim credit for, but not really bear the cost. And so one could argue that having them pay the cost through the low-income subsidies puts the onus on them to say, look, if we really think this is an essential service that ought to go above and beyond, we have to put our money where our mouth is and cover those costs for the low-income folks. Yeah.
Hi, my name is Cheryl Sherrod. I'm a medical student here on rotation in the Preventive Medicine program. And I guess my question piggybacks off of what you just mentioned and coming about from the angle, as long as the shared savings is an ambiguous, there's not a lot of modeling of how that's going to go out. How do you ensure that the ACO has enough coverage to make, a Medicare patient who's in that ACO have adequate care under different specialties and stuff? And how do you prevent the physician providers from, not participating in an ACO? How do you incentivize them to actually participate?
So I guess the flip answer to that last question is, well, hopefully you incentivize them to participate by dangling cash in front of them. But yeah, that's more difficult, easier said than done. So in some sense, there's a couple of thoughts or justifications for some of these rules. I mean, first off, you got to get a significantly large number of Medicare beneficiaries so that if their actual spending exceeds the benchmark, you can feel pretty comfortable that it's because of something the ACO did as opposed to just dumb luck. And, because medical expenditures are very, very random and skewed. So the hope here is that 5,000 people is big enough to get good estimates. And so I neglected to say that the benchmarks will be quote unquote risk adjusted to take into account of the health status for people. So one of the things you mentioned about, well, how are you going to make sure that they're not just, providing, low quality care or just, not providing care when it should be. That's where these 65 proposed quality metrics come into play, right? So some of these are things like, what proportion of relevant aged women received a mammogram during the past year? Like, what percentage of the people received a flu shot? Is the ACO meeting the requirements set forth for electronic medical records? And so the hope here is that if you have 65 good quality metrics that you feel work well, then an ACO that meets more of them is providing high quality care, and you in turn feel good about the fact that if they're saving money here, they're saving money by not sacrificing quality. But then I guess I think many people, health policy analysts, think that there sure seems to be fair amount of evidence of overuse of healthcare services in the Medicare program, right? So the Dartmouth studies have indicated that there's wide geographic variation in Medicare spending without commensurate improvements in health. And so, they've speculated that as much as, 25 to 30% of healthcare spending is wasteful. So if that's true, and if you set up mechanisms and incentives for providers to be able to keep some of the money if they reduce spending, right? So the thing is, reducing spending hurts them, just under the current system because it's less revenue coming in. So the hope here is that if you can say, if you lower your utilization, it's going to lower your fees coming in, but if you lowered it enough, you can share in those savings. Hopefully, this mechanism is going to be appealing enough to primary care physicians and specialists to link up and say, let's do this thing. But we'll see.
Hi, I have a bunch of online questions, but I wanted to first ask a question of my own, and I guess I'm getting old enough to wonder, why are ACOs going to work when managed care didn't work, whether it be a staff model or an open model, and Medicare Advantage Part C is basically supposed to be doing this anyways?
Yeah, so that's a great question, right? And so I guess the answer that I've heard people say who were involved in pushing forward on this is to say we're cutting out the insurers as the middlemen, right? So under the Medicare Advantage model, yes, you send Medicare money to a private insurer, and a private insurer tries to figure out how to coordinate care. But the way that private health insurance company does it is try to figure out how it ought to reimburse the providers and is prescriptive on the providers. And I guess this is similar in spirit because you're pushing some of that off onto to providers, but it's doing away with the insurer as the middleman, and it's just going direct to the providers, cutting out the insurers and saying, you guys figure it out. And so I think the thing is, well, can they figure it out? We'll see.
Okay.
Sorry, it's not more optimistic. I don't know.
Yeah, I have a couple of questions that I think must come from our public health community.
Okay.
Could you provide an update for us on where the public health pieces of the ACA are in terms of their implementation? And along those lines, specifically home visiting and the PrEP funding. And also, do you think we'll actually lose public health funding from the states because of this?
So, couple of thoughts there. So one is that the Affordable Care Act is really medical care, healthcare focused, and the amount of public health provisions that are in there are just like dwarfed by all the stuff that's going on with respect to medical care. So in some sense there's just not a lot to begin with. But in terms of what's there, yes, it's been now a target because, as I mentioned earlier, one of the strategies from Republicans have been to do this death by 1,000 cuts. And so if they don't have the ability to just kind of overturn the whole thing en masse, well, what they can do is maybe pick apart different provisions and quote unquote defund them. And so I think within the past week, there's been a lot of attention placed on trying to defund the, I forget what it's called, but a preventive Services Trust Fund type.
Prevention and Public Health Fund.
Yeah. So they're going after that, and I don't know where things stand actually. I don't think they've voted upon it yet, but I think it's close.
Did you have a question?
Hi, I'm Babai Mohit. I'm in Health Policy and Management. I have actually two questions. So during the debates that were going on about the bill, there was a lot of talk about how health IT initiatives can help save costs. Beside the online exchanges, has there anything else in the bill that moved towards the directions? And my second question is about the 65 quality indicators. Who's setting them? What are the standards? If you could explain a little bit about more
Okay,
about
so
that.
maybe I'll do that. Yeah, that second question first.
Okay.
So CMS is essentially Center for Medicare and Medicaid Services essentially put out the proposed rule for reimbursing accountable care organizations under the Medicare Shared Savings Act. And in there, among the 400 odd pages, there's a table that suggests 65 of these things. And they essentially, tried to rely on like what the literature has done, what insurers have used in terms of something called HEDIS scores, and pulled it all together and said, seems reasonable to us. Like, what do you all think? And so the process is such that provider groups, insurer groups, advocacy organizations for patients will look at them and weigh in and make suggestions and maybe add some, maybe knock some out. That's kind of the process. So the IT one, health IT, there's actually very little in the Affordable Care Act related to health IT, in large part because it was included in the 2009 stimulus, the American Reinvestment and Recovery Act. So what the stimulus did, a year prior, and many people kind of think about, the health IT funding, that's all part of healthcare reform because it was done within, the first year or so of Obama's administration. It does a couple things. I think probably get this, gloss over a lot of the fine details, but in some sense it kind of just trying to set up the infrastructure of also termed exchanges, information exchanges. Somebody's got to give up on the exchange because it's too confusing. But it set up information exchanges, regional information exchanges, to eventually get all these systems to talk to one another. The other thing that was a big component of the stimulus bill was to try to incentivize physicians in particular, but also hospitals, I believe, to actually purchase these systems, right? So they're very expensive, and many physician groups, particularly small ones, probably say, well, like, what's in it for me right now? Spend all this money on an expensive health IT system, like, where does the benefit accrue to me? So the stimulus kind of used this carrot and stick approach to say, well, we're going to have you demonstrate, quote unquote, meaningful use of adoption of health IT. And if you do, we're going to increase your Medicare payments a little bit. And so that should be the incentive in turn for getting these providers to go ahead and adopt. But there too, there's a lot of uncertainty in terms of defining meaningful use. My understanding is the Office of the National Coordinator for Health IT came out with some proposals to demonstrate meaningful use, maybe like 40 or so measures, and the provider community was like, what? Say that again? Like, you want us to do all 40? So there's a lot of pushback in terms of, I think, what will, ultimately constitute meaningful use. And I'm not so sure where they are in that process.
I have a question from Blue Cross Blue Shield of California who's listening. The question they ask is, what impact do you think the Medicare ACO guidelines will have on private insurance? And then a follow-up from a different listener asks us, what do you think all of this legislation will do to newer technologies, fusion technologies, diagnostics, therapeutics,
Okay.
et cetera?
So the first one in terms of private insurers and ACOs, my guess, my impression as well, is that private insurers are just kind of waiting to see how this all plays out. And so if Medicare can be the leader and set up these rules and incentivize providers to come together and form ACOs, then private health insurers would probably follow and say, okay, great, this ACO exists. Let's think about paying the ACO for the care in this way. So I think if the ACO it's not a demonstration, but if the ACO element takes off in Medicare and is successful, then private insurance will follow. The other one, in terms of what all this might mean for technologies, the feeling I have on the overall literature is, if you just look at the rising healthcare costs, increasing healthcare spending as a percentage of GDP, there's a lot that factors into that. But the main driver is certainly development of new technologies that on net are probably worth the cost because it makes us healthier. It's probably a bit of a controversial thing to say, but it's fairly good literature out there saying, yeah, all these things might be worth it. It's just a challenge to figure out how the heck we're gonna finance it all. So with that said, what will the Affordable Care Act mean for that? I think in the short term, it's going to have a slight bump up in medical spending, because you're going to have essentially 30 million or so uninsured people who receive some care now, but not enough, gain insurance in 2014, whether through Medicaid or private insurance, and start to consume medical care. Sometimes it's referred to as pent-up demand, right? So they have demand for healthcare that's been pent up because they haven't been able to afford it, and that'll probably persist. But I think there's also some hope that certain elements of healthcare reform, maybe the reductions in payments to hospitals from Medicare off into the future, maybe the incentives that'll result from the Cadillac tax on expensive health insurance plans in the private sector come 2018, again, if hell freezes over, might cause incentives for, or might yield reductions in medical spending, essentially because the payers are paying less for it, right? So I guess now you could think of this oversimplified view of this of providers as saying, well, new technologies come along, let's purchase them, let's acquire them, let's provide them, because no payer is telling us that they're not going to pay for them. And so that'll probably persist until payers start doing something differently. And so on the Medicare side, I guess what they'll do differently is just slow the growth in the annual updates over time. And so hospitals will realize, well, we're getting paid less, so we're just not going to be able to maybe acquire some of these new technologies. Or maybe there will be added incentives to try and find technologies that actually lower costs. You can probably say a similar thing on the private insurance side, that private insurers will respond to things like the Cadillac tax and come up with benefit packages that are relatively less generous, don't cover certain drugs, don't cover certain procedures, and that's what people will want because they don't want to incur the costs associated with the tax.
Hi, my name's Lauren. I was just wondering, getting back to whether the ACOs would work or not. It looks very similar and to group health in Seattle, and from what I can tell, that they've done quite well, especially with their new patient-centered medical home model of reducing costs and improving both patient and physician satisfaction. And I was just wondering if that was maybe one of the influences of changing to something like an ACO in the bill. I don't know if you've had.
Yeah. So I think there are similarities and differences. So I guess starting with the similarities. I mean, so my understanding of group health in Washington is that it's essentially a co-op plan that is salarying their physicians, right? And so doing that, along with, say, Mayo Clinic and other anecdotes you can find, sure seem to be consistent with lowering costs. And that's essentially because you've taken away kind of the incentives for some of these providers to provide more and more care because it impacts their remuneration. So, and I think you can think about like those places not only changing the way providers are paid, but also tilting things towards primary care and prevention. I think the similarity with ACOs is that they too are trying to emphasize prevention and primary care and those type of things, but through a very different mechanism, right? So the ACO model is not one in which necessarily these providers would get salaried, for instance, like the co-ops. The thought here is that no, they're going to keep getting paid fee for service like they always have, but we're going to set up something to let them get the money back.
I guess I was just thinking along the lines of like cutting out the middleman and having like a primary care like connected with a hospital.
Okay.
I knew about the truth, like with the physician salary and stuff. But
Yeah, no, that's sorry. No, that's a real good point. So if you think about, I guess, the co-ops as well in terms of them being insurers, yeah, they're insurers, but they're not kind of like the middlemen insurers that you typically think of as, like say the Aetnas and the WellPoints and the stuff. And the ACO approach is similar to that in that it's trying to get payments directly to the providers, and cutting out these insurance middlemen. So yeah, real good point.
Dr. Aaron, thank you so much.
Thanks. All right.
For